Well, thanks so much for joining me today for episode 5 of season 5 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hochman. As always, a big thank you and shout out to the SCAN Health Plan for generously funding and supporting the Healthy Skeptic MD. SCAN Health Plan is California's largest independent nonprofit Medicare Advantage plan. So in the Healthy Skeptic MD podcast, as many regular listeners know, we frequently discuss the overuse of medical services. We covered the risks and harms of aggressive cardiovascular procedures, the downsides of unnecessary screenings and tests. We've talked about the unintended consequences of medications when you're on too many medications and all the side effects. Now, according to my guest today, Dr. Samantha House, who is the Chief of Pediatric Hospital Medicine at the Dartmouth-Hitchcock Medical Center in New Hampshire, these concerns also apply, surprisingly to some, including me, into the pediatric population. So Dr. House recently did a very provocative analysis in JAMA, Journal of the American Medical Association, showing that unnecessary overuse of medical services is both common and costly in a network of pediatric hospitals. Very interesting discussion, so please do stick around for it. If you do find today's episode engaging, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts. And without further ado, let's jump into my discussion with Dr. Samantha House. Well, I'm very happy to be joined today on the Healthy Skeptic MD with Dr. Samantha House. How are you today, Samantha?
I'm doing great. Thanks so much for having me.
Well, we've never worked together before, but I really enjoyed your recent JAMA article, which is what we're going to talk about. But before we jump into that, you are the chief of the section of pediatric hospital medicine at Dartmouth-Hitchcock Medical Center in New Hampshire. Can you tell us a little bit about your clinical practice?
Yeah, that's right. So I am the lead pediatric hospitalist here at the Children's Hospital at Dartmouth, which is tertiary care academic medical center, children's hospital nested within a larger adult hospital. We're pretty unique in that we have a really sort of high level academic center in a very rural area. So it's a nice work-life balance from my perspective. We've got really easy access to the outdoors. But also have a really large catchment area. So we take care of really most of the kids in the state of New Hampshire who have any high acuity illness that requires subspecialty care or critical care here at our children's hospital. As the lead for the hospitalist section, I'm managing our group taking care of patients who are not critically ill, but are really interesting and complex. So we have a nice mix of kind of bread and butter pediatric conditions. We have a large population of kids who have a pretty high degree of medical complexity and see many of our subspecialty teams here. And then because of our catchment area, we also get a lot of really interesting cases that are sort of the diagnostic puzzles.
And how have things been going during the pandemic? Has there been a lot of COVID-19?
Yeah, great question. So we, for reasons we don't really well understand, we're pretty well spared through the early part of the pandemic here. We did really well. I think we have the benefit of sort of our rural geography and people being able to distance and not experience some of the crowding that we saw in more urban areas. We recently have seen our peak, so really it's been in the last 4 months that we've seen the highest numbers of cases that we've seen throughout the entire pandemic. We definitely have seen some pediatric COVID. We have admitted children with COVID diagnoses. A lot of the kids we're admitting with COVID are admitted for another reason, so they're coming in for something either unrelated to their diagnosis or sort of mildly symptomatic from their diagnosis and then are getting tested on admission and finding out they have COVID. And that's a pattern that we're seeing in other places as well. And then more recently, we've also started to see some kids coming in with what's called MIS-C, which is the post-COVID inflammatory syndrome. So overall, we've done pretty well. I would say our numbers have not been super high, but again, this is sort of our highest time thus far.
Well, hang in there. Hopefully with this Omicron surge, you guys don't get overwhelmed, and it sounds like you're handling it all pretty well. One last warm-up question. How did you get into the field of pediatrics?
Yeah, I don't know. I liked working with kids. It's sort of such a generic answer. And whenever I'm asked this question, I reflect on my sort of originally designed training path. And I did, going into medical school, think I was going to go into emergency medicine. That was very much sort of the path that I was on. I liked the pace. I liked the procedures, the acuity of patients that we saw in the emergency department. And I think even in medical school, I started to recognize some aspects of our healthcare system that were a little bit suboptimal. And particularly in the emergency department setting, I was recognizing people who were coming in for emergency care who may not have needed that had our systems, our medical system and our social system sort of better supported them outside the hospital. And so I felt frustrated by that, and thought that would be a little bit better if I went into pediatric emergency medicine. So I came to peds residency because I enjoyed the kids and I thought I would be a peds emergency physician, and then ended up sort of changing course and becoming a hospitalist.
Well, liking kids seems like as good a reason as any to go into pediatrics. Good answer there.
They're fun. They're, they don't give you a hard time. They're usually in good spirits.
Yeah, well, I do adult medicine. Adults are not always as fun, but they're more compliant when you tell them can I look in your ears? So that was what my decision-making process was. Well, Samantha, we've done a lot on the Healthy Skeptic MD, looking at the problem of overuse of medical services. We've looked both at the cost, but more importantly at the harms of overuse. In fact, I had your colleague, Dr. Elliot Fisher, who's one of the godfathers in this field. He's at Dartmouth a few months ago on this. So check that episode out if you haven't heard it yet. But how did you become interested and concerned about the issue of overuse of medical services?
Yeah, so it was actually exposure to some of the godfathers, as you mentioned, that I think pulled me in this direction. So before I went to medical school, I did a master's in public health at the Dartmouth Institute for Health Policy and Clinical Practice, which we called TDI and had a different name back when I got my degree there. But folks like Elliot Fisher, Gil Welch, who's sort of famous for recognizing the potential.
I've had him on the podcast too, actually.
Oh, I haven't seen Gil's. Okay, so
an overuse of screening for cancer. That was about a year ago.
So I was fortunate enough to have those individuals and other like-minded folks as really primary professors through my year of my MPH. And certainly overuse was not something I was sort of coming in thinking about, but Dartmouth has really made a name, as you know, in looking at unwarranted variation in healthcare delivery. So where is the intensity of service delivery high, and is that related to the intensity of illness in that particular area? The answer is often no. And so I had the opportunity to learn from really sort of the founding fathers in the field, if you will, over the course of that year. And then I came back to Dartmouth for residency, and pretty early on in my pediatric residency got hooked into research focusing on overuse in pediatrics. And so I had sort of a string of strong mentorship, and I like to tell people I drank the Dartmouth Kool-Aid. I don't know if it would have been avoidable for me to become interested in this just with the expertise and the passion around here.
Yeah, well, Dartmouth has certainly done an amazing job breaking down this issue in the Dartmouth Health Atlas, which looks at variations, as you said, how some regions of the country use medical services very differently. But what I thought was really interesting about the work you've done, I don't typically think of pediatrics as an area of overuse or wasteful, harmful care for many reasons. One is that kids tend to be healthier, tend to get less medical care than adults. And the other is that, I think that many pediatricians are appropriately more cautious about the harms of aggressive treatment in kids. But is that perception not accurate that I have?
It's a great question, and I guess several comments in response to your question. So one, it is true that kids are healthier. That's part of the reason that taking care of them is often fun, because we take good care of them and they get better. What we know, though, is that a lot of the diseases that influence or impact kids are self-resolving. So kids come to the hospital with viral infections, and they're seen in outpatient clinics with colds. So there's a lot of sort of everyday medical care for kids that is related to diseases that we don't have a cure for. And that's an uncomfortable position as a clinician. So I spent a whole bunch of time in the last few years looking at the psychology of overuse. We spend a lot of time focusing on systems pressures that drive overuse and sort of other factors. But there's also we possess as healthcare providers this inherent action bias. And so it's very hard for us to sit by and do nothing, even when a condition might warrant that. And so in pediatrics, we're kind of constantly faced with this issue of, okay, we've got a sick kid. We know from all the resources that we have that they're likely to get better over time, But right now they're suffering and their families watching them suffer, and we want to be able to do something for them. And I think in pediatrics that's led to the same process that has led to in sort of all other facets of medicine, which is the constant pursuit of something that's going to help. And, the classic story in pediatrics, and the one that gets most people in pediatrics hooked on the problems related to overuse, is the story of viral bronchiolitis. And so viral bronchiolitis is inflammation of the lower airways associated with a viral illness. It's often RSV, but lots of other viruses can cause it. There's a pretty famous article that was written in the 1960s that recognizes that bronchiolitis is a mild illness typically and is self-resolved. And there's a famous quote that I won't exactly quote, but from that article that basically says we shouldn't fritter away our energies trying to identify therapies that are going to help, because this is just going to get better on its own. So you support the kids and it improves. That being said, we spent the last 60 years frittering 50 years frittering away trying to find something that works. And so, every decade there's something new that people are studying or exploring, whether it be a medicine or a particular kind of intervention or monitoring strategy. And, we put a lot of resources into studying these things. There's been a lot of good trials done. And at the end of the day, we're right back where we were in 1965, and that nothing really changes the disease outcome. So, long story short, I think you're right. I think when we talk about pediatric healthcare, especially in the United States, it seems like a really small piece of the overall sort of puzzle in American healthcare. But we know that there's a lot of overuse happening. And as you mentioned earlier on, there is harm associated with any overuse that we need to be paying attention to.
Well, that's a great explanation for it. And, what's interesting there is that, the bias to do more isn't necessarily coming from a bad place. Everyone wants to be able to help. You see a child or whoever it is suffering, and you want to give a pill, you want to give a treatment, you want to do something. The problem is, in many cases, particularly for kids who are going to do so well, that there really isn't anything other than letting time take its course and the natural immune system, getting that child back to health. So what motivated you to do this study that was published recently in JAMA? What was the rationale there?
Yeah, good question. And I can't take full creative license on the study idea. So the senior author on the study, Dr. Mario Reyes, had done some prior work in this area, really trying to measure overuse of individual services in administrative databases in pediatrics. I, on the other hand, have done some work looking at what's out there in the universe for pediatric quality measures and what those measures look like and whether they're representing what they should be representing for pediatric care. And so he and I sort of connected over this shared area of interest at a national meeting, back when we used to have national meetings and could connect with people at them, and really started to develop a vision about how we might broaden this work in pediatrics. But basically what we did was create a calculator that represents low value care within this particular database. There's a similar sort of product out there that contains 50 measures of low value care that are mostly relevant to adult populations, that's been used in the research setting and has been used even at the state level to try to quantify low value care. And so we looked at that and sort of said, can we make an equivalent that's really focused on pediatric hospital-based care?
And what did you find in your study?
Yeah, there's been a lot of learning from this work. So, I think the first thing to say before we even delve into the actual study findings is that we've learned a lot about trying to measure what we're calling here low value care. And I put that term in air quotes because that language is hard for people. And when faced with individual data on how much low value care you might be providing, the tendency is to say, the patients I saw were different and the patients I saw warranted this care. And so we know that this is sort of an emotional territory we were wading into, and tried to be really thoughtful around how to create the first iteration of this product. So in order to understand our results, I think it's important to know that we created measures that we describe as being very narrow. They have a lot of restrictions. So we removed kids with really serious long-term medical illnesses. We removed kids who were hospitalized in an intensive care unit because those kids tend to sort of fall off of our pathways and algorithms. The evidence to support what care is right and what care is not ideal in those populations is really thin. So we tried to stick to sort of a very basic general pediatric population. And then for each individual service that we included, we built a measure definition that really tried to exclude scenarios that might have been justified. So for example, if we're looking at antibiotic administration for a child with a viral illness, we actually excluded anyone who had a diagnosis of a bacterial illness. So number one that we found is that measuring low value care is hard. There's some subjectivity involved. There are different ways to do it, and we need to continue to work on understanding sort of the most optimal ways to get at the truth, or as close to accurate representations of low value care as we can.
And I just want to second that point. As a practicing doctor, what's on paper does not always match what actually happens in reality. You do your best to code things. So just because an administrative data set suggests that something's low value, neither of us was involved in that individual patient interaction, and there are nuances there.
Yeah, I think that's absolutely right. And I think it's important for me to have an opportunity to say we 100% recognize that and really try to address that in our limitations.
So your first finding was it is hard to measure low value care, but nevertheless, the data do provide some trends.
Yeah, but we're still learning, and the data do provide some trends. So, I think a couple of important findings from the study. One is that, despite these really narrow definitions I've described, we still see a fair amount of low value care being delivered, even in generally sort of healthy, no medical comorbidity type populations who are not intensely ill. And, the conditions that we saw a lot of overuse in varied in the study. We looked at emergency department cohort and an inpatient cohort. But common things like bronchiolitis and asthma and pneumonia still have a lot of low value care or overuse for pediatric patients in the hospital setting.
One thing, Samantha, that really caught my attention in your article was that children under 3, nearly 40%, with sore throats were getting tested for strep throat. Why is that a problem?
Yeah, good question. I like this measure actually, because it's a really simple measure. It's very straightforward. So kids under 3, classically, when they have sore throat, are most likely to have a viral illness. And actually, the bacteria that causes the strep sore throat that you or I might think about if we have a sore throat and feel really yucky, doesn't tend to cause that presentation in very young children. It can cause other things, but doesn't typically cause the sore throat. So testing that population for strep is testing a population that has a very low pre-test probability. The likelihood that you're going to find truly problematic strep in that population is quite low. The other issue is that the reason that we tend to treat strep throat is to avoid sequelae. And so acute rheumatic fever is a condition that can happen after a strep infection that we really want to try to avoid because it can be quite dangerous and quite harmful. And that is also incredibly rare in this particular age group. And so there are Infectious Disease Society of America guidelines that recommend that we do not test kids under the age of 3 with a strep swab when they present with a sore throat, because they're not likely to have strep, and if we miss it, the consequences are not particularly high. So lots of good reasons not to test this population. I think the question that people often ask is, why does this really matter? It's a Q-tip in the back of the throat. It's not very expensive. And I think that's a reasonable question. Apart from the potential predisposition to unnecessary antibiotics, the things that are important here to me are, one, kids don't really like to have stuff stuck in the back of their throat, frankly. It's not that fun for them, and if we can avoid it, I think we should. 2, there is a cost, and a single test is not particularly expensive, and it's not expensive as, nearly as expensive as some of the other therapies we do, but there's cost-saving potential there. But the more important feature to me is that the perceived need for strep testing actually drives healthcare utilization. So if you're a parent of a kid who's 2 and your perception is that when your child has a sore throat, he or she needs to be tested for strep, you're going to seek care each time that child has a sore throat. And so the office visits, maybe the emergency room visit, if it's 11 o'clock on a Friday night and you can't get to the office, those are all other costs that need to be considered as we look at this particular practice.
Yeah, it's almost like a game of dominoes. A test begets another test, begets an antibiotic that may not be necessary. So the initial test may not seem such a bad idea, but then all the downstream things that result. Another one that really caught my attention was a lot of CAT scans being ordered for kids with head injuries. I certainly know from having kids, they bang their head, bump their head all the time. And one of the key decisions when a kid presents with a head injury is, do we need to get a CAT scan? There's radiation and other downsides of doing that. So what did you find here?
So this is another important measure, and is a tough measure because it's a high stakes measure. So this has been an area of quality improvement focus in emergency departments for a long time, because unnecessary radiation carries with it important side effects that we really want to avoid if at all possible. And so judicious use of CT is really critical to avoid those complications or risks. However, missing a serious head injury is also something that obviously we want to avoid, and that I think probably prevents some emergency room physicians from sleeping at night, right? That's a miss that we really don't want to have, and that could have very high consequences. So we felt it was important to look at this measure. There are criteria, sort of national criteria, around when you should or should not do a head CT based on clinical presentation. However, even at the clinical level, when you're seeing a patient, sometimes you're missing information, and sometimes it's hard to make a decision. A parent might think that a child had a period where they lost consciousness, but they may not know because the event may not have been observed. So there's a lot of gray area that goes into the decision making. In full disclosure, we've had a lot of pushback on this measure for that reason, and others have at times avoided this measure because there's a fair amount of sort of detailed information that goes into the decision making that may not be accessible by chart. We chose, or by administrative data. We chose to look at it because we felt it was important, and another aim of this work is really going to be to look at trends over time and look at variations between hospital systems. So, even if our measure definition for low value care is imperfect, we want centers to be able to say, okay, I'm doing better or worse than my peer center, and we want to be able to say this is getting better or worse over time. So that's why we opted to include this measure. We did see a fair amount of head CT utilization, almost 20% of the eligible encounters that we determined to be sort of encounters that shouldn't have had a head CT did. And again, I acknowledge the difficulties in really accessing what every individual clinician was thinking or why those decisions were made.
Well, one thing I'll say about the CAT scan issue, and in kids, it is a very challenging and nuanced decision in many cases with pros and cons with the radiation. But I had a mentor who used to say ordering the scan is the intellectually lazy thing to do, because it's always easier just to say, let's get the scan, let's be safe. But the other approach is to actually spend some time, do a thorough exam, ask those detailed questions. And if you can get reassurance from those exam questions and the physical findings, you can almost entirely exclude severe injuries without getting a CT scan. So the other one that really caught my attention, I had a son who has reflux, or did when he was a child. He was constantly spitting up every family photo we had. There's this white goo on his shirt because he was constantly spitting up. And your study found that many times we doctors are treating kids with reflux with medications. Maybe that's the right thing to do, but in most cases, reflux is just a common thing that will resolve on its own. So tell us a little bit about that finding.
Yeah, this one is personal for me as well, with a similar history, but I think is a really important measure because the evidence to support the use of antacid medications in young kids is very poor. So it's non-existent. There's no evidence to suggest that these medications are effective in the vast majority of children who have reflux. And there's also a growing body of evidence to suggest that there may be harms associated with these antacid medications. And in kids in particular, we worry about altering the sort of gut flora or the microbiome, the bacteria that live in your intestines with these medications. And we worry about predisposing to different types of infections, so pneumonia in particular, but for very young babies, sometimes even sort of overwhelming illness is a concern in the setting of treating with these medications. So this to me is a really big problem. These medications can be expensive. I'm often, if for some reason I'm trying to discharge a patient who's on one of these medications and it's been changed at all, I'm being asked to do a prior authorization. There's hurdles to getting these medications for families, and they just don't work. So this to me is low-hanging fruit. What's interesting about it is that it has not been a big focus of quality improvement initiatives, despite the fact that there's really, there's guideline level evidence to say that we shouldn't be doing it. The other thing that I'll point out is similar to what I mentioned for the strep testing, which is that there's a pretty significant consequence to labeling a child with something physiologic as a child now with a disease, right? And so your child had reflux, and probably it was called physiologic reflux, and he may have grown out of it. But once we tag the term disease on or start treating it with a medication, it really changes people's perspectives. And it sets the tone that this is something we can and should treat with medicine, which may very well just be, is very much part of a sort of physiologic spectrum.
Well, that's a great point. And, happily, my son grew out of his reflux, and we never labeled it, and he never took any medications. But it sounds like that's not always the case, at least in terms of getting medications. So another question, Samantha, in the article, you mentioned cost, and we doctors tend to shy away from talking about cost. We talk about the harms of the safety concerns and the harms of overuse. But you actually did highlight how some of these procedures do cost money and maybe take resources away from other more important things that we could be doing in healthcare. What did you find in terms of the financial of wasteful care?
Great question. And cost is hard to measure, and it's particularly hard to measure across different hospitals because there's all kinds of factors that influence local cost assignments, including geography and a variety of other things. So the cost numbers that we report in the study are simply sort of the direct standardized cost associated with the delivery of these low-value services. And our study looked at a single calendar year, and we reported $17 million in cost across the hospitals associated with low-value care.
So $17 million over a calendar year among the 48 hospitals that were in your network.
Yeah. And I think it's important to talk about that number and interpret it with caution for a variety of reasons. So one, I would not make the assertion that that is the cost of low value care over the calendar year, right? We have found a set of evidence-based low value care measures that reflect a very small proportion of the low value care that we provide overall. And then we've taken those measures and come up with these very narrow definitions and excluded lots of different populations. So, I would look at that as the very, very, very sort of tip of the iceberg. I think the other piece that we're not capturing is the cost associated with what we call the cascades of care. So what happens after you deliver this low value service? And we talk about this a lot for bronchiolitis. So one of the more recent therapies that we've adopted for bronchiolitis is called high flow nasal cannula, which is an alternative oxygen delivery device. And in many hospitals, in order to get high flow nasal cannula, you have to move to an intensive care unit. And there's a lot of question. There's no evidence to support that high flow nasal cannula is changing outcomes for kids. And yet we're changing our care patterns in a way that is significantly more costly. So in our current study, we don't have any information around sort of the other cost impact associated with some of these services.
So it certainly sounds like that 17 million is probably an underestimate of the true value. Is that fair to say?
Yes, absolutely. A big underestimate.
So one last question for you. I think your study did a great job of highlighting the problem and really changing my mindset that overuse is not a problem in kids. But then there's the tricky part of what to do about it. Are there policy solutions or other educational solutions? Would just love your high-level thoughts on how do we start addressing overuse in pediatrics?
Yeah, it's a big question. It's the $1 million question, or the maybe many $1 billion question, right?
Or maybe even a $1 trillion
$1 trillion
question,
question.
looking at our healthcare budget.
Yeah. So, several things. One, I am not a policymaker, but I think it's relatively clear that we need to continue to work toward payment reform. I believe in quality-based payment structures, but I also believe that we need to get them right in order for them to be effective. I think that does involve incorporating more overuse measurement. I don't think we've been able to prove that accountable care organizations or alternative payment models are particularly cost saving as of yet. And I think that will be hard until we really start to pull in more measures that are associated with services that we need to be de-implementing or trying to get rid of. And so I think focusing on how to bring those measures into the equation as we craft alternative payment models is going to be important. I think as we do that, it's important to be looking at other domains of quality as well. So there is hesitancy, right, in thinking about, people sometimes talk to me about, are you rationing services? Why are you trying to take care away from my kid? So I think we also have to be keeping an eye on other domains of quality. Is what we're doing patient-centered? Is it timely and effective still? And how is it contributing to outcomes? And I think we've been hindered to some degree by sort of the monstrosity of our healthcare system. One place that we need a lot of help is data. So, I have access to this particular database to do this research work, but this is just a small subset of kids who are getting pediatric care in the hospital setting in this country. There's lots of kids getting care at community hospitals and other types of hospital settings that are not represented in this data. And the data around what kind of care they're getting is challenging to access. We don't have good data sharing infrastructure. And so I think continuing to work on that as an improvement strategy is important. I think for pediatric healthcare in particular, I'll kind of circle back to your first question and end on a note of sort of saying that the cost associated with pediatric care is really important. So people look at it as a very small piece of a very large pie and tend to de-emphasize the potential for cost savings. The amount the United States spends on pediatric healthcare is more than most industrialized countries spend on all of their healthcare. And so the small piece is still quite expensive in this really, really giant pie. And because kids are healthy, there really may be an important point here that we really focus on this population as one that we could get rid of a lot of extra stuff.
What about at the individual level? If you're a parent, is there a role to ask, is that test or treatment really necessary?
Yeah, I think there is. And I actually think that the tides are turning a little bit on that front. When we ask trainees and hospitalists and others, why they feel like they have to give a service, they come up with a long list of reasons, and all of them are ones that you or I could come up with as well, right? The family is watching the child is in distress, they want something to be given. So family pressure is almost always on that list. We saw some really good progress with family engagement around antibiotic stewardship. So, I think even at the very start of my training, we were still very much in a place where the majority of families coming in would say, I think my kid has an ear infection, I want the antibiotics, and I want to go. But even in the last decade, with more emphasis on the harms associated with unnecessary antibiotics, we see a lot more families asking educated questions and really wanting to understand whether something is necessary or not.
I think it's a really important point. Healthcare, in my view, is done at the individual level. So these quality metrics and high level policy programs can have an impact, but I really think it is a culture, it's education, it's getting parents in the community to understand that more care isn't always better care. And, I don't exactly know how to do that, but I do know those decisions are made at individual levels. Well, I really appreciate your joining me today, Dr. Samantha House from Dartmouth Hitchcock Medical Center. And if you did find today's episode engaging, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts and on YouTube. We'll pick it up again in a couple weeks. Thanks again for joining me.